Hey guys, it's Olivia. Welcome back to your endocrinology chapter. In this section, we'll be covering pancreas physiology. And I think this video will really help set the stage for when we later talk about diseases of the pancreas like diabetes 1 and diabetes 2. And before we dive into the embryology and anatomy of our pancreas, first look over here at our adult pancreas. You can see that we have the head of our pancreas nestled into the curvature of our duodenum, the first part of that small bowel that is connecting the stomach to the rest of the small bowel. We then have the body and the tail of the pancreas. And then finally, we have our gallbladder, which will be sharing a duct, the common bile duct, with a lot of our pancreatic secretions that are also going to be draining through that duct into the duodenum. That's a high level overview of where the pancreas is located in the body. But how does the pancreas evolve? First, I want to walk you through a general overview of where we're going with this process. So if you look down here at my handwritten drawing, I apologize for not being more of an artiste, but I think it gets the point across. First, we can see our duodenum. Our duodenum in pink here has several structures branching off of it. First, we can see our gallbladder, and then we have these different buds. These different buds are what is going to create our pancreas later on. So first, we have our ventral bud. You can see our ventral bud in orange is coming off of one arm, and then we have our dorsal bud. Our dorsal bud in yellow is coming off of the opposite arm. And what you may notice about the snapshot of embryology here is that our dorsal and ventral bud are on opposite sides of the duodenum. They're kind of splitting the duodenum, which of course, since we looked at the adult version of the pancreas, we know that's not how it ends up in real life. So what's going to need to happen here is our ventral bud are going to have to rotate around the duodenum. And you can see in this second snapshot how these buds are kind of rotating and twisting to get onto the same side of the duodenum where the dorsal bud is. And as they're rotating and twisting, eventually they rotate so much that they detach from that opposite side of the duodenum. And in our third snapshot over here, you can see that our ventral buds, these ventral buds in orange here, now are fusing with our dorsal bud to create this one contiguous pancreas. These ventral buds, as you can see, are making up parts of the head because they are where the head would be. And then our dorsal bud in yellow is making up more of the body and the tail. So to quickly recap some high points about pancreatic embryology here, the pancreas is evolving from the foregut endoderm. So both of these buds, the dorsal and the ventral buds, are from foregut endoderm. Around week 4, that's when we have the outgrowing of our dorsal and our ventral buds. Our ventral bud, as we saw down here, is to the right of the duodenum if we are thinking about anatomical position. And then this will evolve into the pancreatic head and then part of the pancreatic duct. As we talked about down here, this twisting of the ventral buds will fuse and then make the pancreatic head. And then you can see part of the pancreatic duct in the head, and that will be the contribution of the ventral bud to the pancreatic ducts. Our dorsal bud is in yellow, and it starts out to the left of the duodenum in anatomical position. This is going to create the pancreas body and the tail. Additionally, the dorsal bud gives rise to our accessory pancreatic duct, as well as the parts of our pancreatic duct which are contained within the body and the tail of pancreas. Around week 6 is when we see this rotation of the ventral bud. And if you remember down here, our little diagram, we remember the rotation of the ventral buds to the left of the duodenum. That's occurring around week 6. And then week 7, we would get our dorsal and our ventral ducts fusing. So if you look down here in our diagram, this would be around week 7. We can see that we have our parts of the ventral bud that are making the head fusing with the body and the tail that is contributed by the dorsal bud. And as well, we are going to have the parts of the ducts that were contained in each the head and the tail fusing with each other. And that is going to create this one long pancreatic duct that I've outlined in blue here. And that is when we finally get this long contiguous pancreatic duct with contributions from both the ventral and the dorsal bud. So that's what's happening in normal pancreatic embryology. But what happens if we have a defect in this process? There's 2 defects you should know about for step 1. The first is called annular pancreas. In annular pancreas, the problem is we have an incomplete rotation of the ventral bud, leading to a ring of pancreatic tissue that is around the duodenum. So if you look down here, around week 6, where we have this rotation of our ventral bud, if it doesn't completely rotate, then you're going to have pancreas on the left side of the duodenum and pancreas on the right side of the duodenum. And that's going to create a ring of pancreatic tissue that is around your duodenum, and it's kind of strangling your duodenum, if you will. That is why when we are strangling this duodenum, the presentation for annular pancreas is going to be really similar to duodenal atresia, because basically you've created an obstruction in that duodenum that's very similar to if the rest of the duodenum just hadn't formed. So similarly to duodenal atresia, you're going to see abdominal pain, bilious emesis. Remember, it's important that this emesis is bilious because it is coming from downstream of the stomach. You got the great diagnostic clue. It occurs usually in neonates, and there is an association with trisomy 21 or Down syndrome. So often, trisomy 21 or Down syndrome will be part of the presentation for annular pancreas on your board's exam. The other problem that we can have with our pancreas embryology is pancreas devisum. And this is when our ducts fail to fuse. So remember we talked about around week 6, we are going to have fusion of the duct that came from the head of the pancreas and the ducts that came from the body of the pancreas or from the ventral and dorsal aspects of the pancreas respectively. And this is going to lead to a distinct dorsal and ventral duct because they didn't fuse, they're not connected. And as you can imagine, if these ducts are not connected, that leads to a problem draining the pancreas, which can cause inflammation in the pancreas. The pancreas gets really angry and clogged up, and that is what is going to lead to pancreatitis. So pancreatitis is going to be the common presentation for pancreas devisum, whereas abdominal pain and bilious emesis in a neonate will be the presentation for annular pancreas. Now that we've talked about the embryology of our pancreas, let's get into some anatomy. The head of the pancreas over here is in close proximity to the duodenum. It's the most common site for pancreatic cancer, so that is going to be helpful for you to know. It also is important to remember if we have a pancreatic cancer in the head of the pancreas, it can also obstruct the duodenum. Drainage of our pancreas occurs first through the pancreatic duct. That pancreatic duct is draining most of the pancreas from the tail, the body, and the head. It is going to join up with our common bile duct. If you look over here, our common bile duct is draining both the gallbladder, and then the common bile duct and the pancreatic duct join together at the ampulla of Vater or Vater. And then both the pancreas and the gallbladder will empty together through the common bile duct into the duodenum. And that is when the contribution of all the bile acids, the bile salts, as well as the pancreatic enzymes that are going to be necessary for digestion throughout the rest of the small bowel contributes to the chyme that is inflowing from the stomach and into the duodenum. Now, the blood flow of our pancreas, the superior head is going to receive arterial blood supply from the celiac artery, going to the common hepatic artery, the gastroduodenal artery, and the pancreaticoduodenal artery. So if you look over here in our image, right here we have the celiac trunk. The celiac trunk has 3 divisions, right? The one that we are most interested right now is the common hepatic artery. So we have our celiac trunk draining into our common hepatic artery. Our common hepatic artery gives rise to our gastroduodenal artery. Our gastroduodenal artery drains into the superior pancreaticoduodenal artery, and that is what is going to supply most of the superior aspect of our pancreatic head. The inferior aspect of our pancreatic head is going to come from the superior mesenteric artery, which is draining into the pancreaticoduodenal artery as well. So if you look down here, we have our superior mesenteric artery. That is a different branch than the celiac branch. And the superior mesenteric artery is also going to have its own drainage into the pancreaticoduodenal artery, so those connect. And this collateralization of the superior mesenteric artery also supplying the pancreaticoduodenal artery as well as the celiac artery supplying the pancreaticoduodenal artery is actually really clinically relevant. And I think it's really interesting as someone who wants to go into vascular surgery. Because if you have an aneurysm or an outpouching of your aorta, weakening of the aortic wall, and you need to treat it by putting a stent or a stent graft inside of the aorta, and that aneurysm happens to be in the region of the celiac artery, in certain cases, it is feasible to completely cover and occlude the celiac artery without damaging these end organs because of this very important collateral supply with the superior mesenteric artery also pumping blood through the pancreaticoduodenal artery into the gastroduodenal artery. And that collateral supply, when it is sufficient, can continue to perfuse these organs even when you obstruct that celiac artery. So I surely would not ask you about this on step 1, but I think it's a very interesting clinical tie-in, and hopefully it helps you remember some of the blood supply in this anatomy. The body and the tail of the pancreas is supplied by the celiac artery draining into the splenic. So you can see our splenic branch coming off of here and all of these little branches that are coming down and supplying the tail of the pancreas. For our venous drainage, the head is going to drain into the superior mesenteric vein, and the body and the neck are going to drain into the splenic vein. Now, what about our physiology of the pancreas? Well, the pancreas's job, it has 2 functions. It has exocrine and endocrine function. The exocrine function of the pancreas, remember exocrine means things are exiting the body, is to secrete digestive enzyme, ions, and water into the duodenum via the common bile duct. And remember, when we say things are exiting the body, for the purposes of step 1, you really should consider the GI tract as a contiguous lumen from mouth to anus as outside the body. That's why there is an entire science of pharmacokinetics that is focusing on what actually gets absorbed from that GI tract and gets to enter the body, because not all of your drugs do, right? Every drug has a different bioavailability depending on if it's an oral or IV formulation. Just remember that. Remember that the GI tract is outside the body for purposes of step 1. And so when our pancreas is secreting these digestive enzymes, ions, and water into the duodenum, since these things are exiting the body into this outside of the body space, This is the exocrine function of your pancreas. Several important enzymes are secretin. Secretin is going to stimulate the pancreas to secrete bicarbonate-rich fluid, as well as cholecystokinin. Cholecystokinin is going to stimulate secretion of digestive enzymes such as trypsinogen, lipase, or amylase. These are very important enzymes for detecting pancreatitis, which we will talk about in a later video. And then that brings us to the endocrine function of the pancreas. And the endocrine function of the pancreas is primarily carried out by these islets of Langerhans. And these islets of Langerhans are going to be producing glucagon, insulin, and somatostatin, which are three very important hormones for regulating metabolism as well as digestion in the body. And for the purposes of step one, it is going to be important to remember not only what the job of each of these hormones is, but also which cells secrete them. So our beta cells are going to be responsible for secreting insulin. Insulin leads to increased intracellular glucose, increased glycogenesis, and increased glycolysis. If there's one cell that you remember what hormone it secretes, I would vote that it is the beta cells because it comes up so often on STEP. It's great to remember that the beta cells are responsible for secreting insulin. The alpha cells secrete glucagon, and I always think about beta and alpha as being opposites, as well as insulin and glucagon being opposites in the body. Glucagon is going to increase blood glucose, increase glycogenolysis, and increase gluconeogenesis. So it's basically stimulating all the processes that are the opposite of insulin because, of course, you secrete glucagon when your glucose is gone and you have low glucose in your body. And then finally, we have our delta cells, and our delta cells are going to create somatostatin, or as I like to call it, somatostopin, because somatostatin or somatostopin, its job is to slow down all of these secretions in the body, decrease GI secretion, decrease pancreatic secretion, and decrease pituitary secretions. Now, I know that was a lot. Let's quickly recap what we talked about in this video. First, we talked about embryology, where we have our pancreas starting out as two separate parts, our ventral bud and our dorsal bud. The ventral bud eventually rotates and then they fuse around week 7. There's two main problems that can occur with this embryology. Either you get an annular pancreas because you didn't rotate your ventral bud enough and now you're strangling your duodenum, so you're getting this bilious emesis and nothing can pass through, associated with Down syndrome, trisomy 21. Or you get pancreatic devisum because we didn't fuse our duct together at week 7. And if we don't have a fused duct, then we can't drain our pancreas and we get inflammation and pancreatitis. In terms of the anatomy, remember that the head of our pancreas is supplied by the celiac trunk and the SMA, whereas the tail of our pancreas is supplied by the splenic artery, another branch of the celiac trunk. And then remember, for the physiology of our pancreas, we have an exocrine function as well as an endocrine function where we have our beta cells making insulin, alpha cells making glucagon, and delta cells making somatostatin. Okay, but how do they ask you about this on a board-style question? Well, something they might ask you is a 45-year-old woman presents to the ED for 3 days of worsening epigastric pain radiating to her back. She states that this pain is worse after eating and gnawing in quality. Thorough studies reveal an elevated lipase, and abdominal ultrasound reveals an enlarged pancreas and several calcifications in the gallbladder, an obstruction of which structure is most likely causing this patient's presentation. Okay, so our patient is having pain in her back, and that should make sense to you because the pancreas is one of our retroperitoneal organs, meaning it is behind the peritoneum and it will cause pain in your back if you do have a pancreatitis. So this is suspicious for pancreatitis. We also see stones in the gallbladder on our ultrasound. These are very suspicious for cholesterol stone. And it's important to remember that an ultrasound is more sensitive to pick up these stones than a CT is. So ultrasound is going to be better for picking up these gallstones. And if we have the setting of pancreatitis and these gallstones, elevated lipase, so we're very suspicious for pancreatitis. And the question asked us, where is the location of an obstruction most likely causing this? It's a great bet that we're talking about a stone located in the common bile duct, where it is preventing drainage not only of the gallbladder, but also of the pancreatic duct into this common bile duct. If we have a big old stone right here that is blocking the common bile duct below the location where the pancreatic duct drains into it, then we of course are going to get buildup not only of our bile salt, but also of all those pancreatic enzymes and ions that are trying to drain out of our pancreas. That is going to cause irritation of the pancreas as well, and it is a common cause of pancreatitis. Now, that's all I have for you on pancreas physiology. I hope that was helpful, and I'll see you next time.